If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. In today's episode, we're going to review the draft NICE guideline on type 2 diabetes, focusing on the main changes applied to 7 specific groups of patients. Right, let's jump into it. And as you may know, the draft guideline is open for consultation until October, and the final guidance is due in February 2026. So let's not forget that it's only a draft and we should not be making clinical decisions based on it yet. Today's episode is based on the visual summary created by NICE, and the link to it is in the episode description. The visual summary includes specific guidance for 7 different groups of patients. In today's episode, we will cover 3 of the groups and we will finish the rest in next week's episode. There are 7 groups. First, the group of patients with no relevant comorbidities. Then, obesity, frailty, CKD, heart failure, atherosclerotic cardiovascular disease, and early onset type 2 diabetes. So let's start with the no relevant comorbidities group. For adults with type 2 diabetes and no major comorbidities, the draft recommends metformin plus an SGLT2 inhibitor from the outset. If metformin is contraindicated or not tolerated, then an SGLT2 inhibitor alone should be offered. If further glycemic lowering is required, the next step is to add a DPP4 inhibitor, and if this is not effective or tolerated, we can try a sulfonylurea, pioglitazone or insulin. This is very different from the previous guidance, which began with metformin monotherapy and only added other agents if HbA1c targets were not met. SGLT2 inhibitors were generally reserved for people with established cardiovascular or renal disease or later in the treatment pathway. The draft changes our thinking on everything by recommending dual therapy right at diagnosis for all, even with people without comorbidities. Why is NICE changing the advice? As we have already explained, evidence shows that SGLT2 inhibitors consistently reduced heart failure admissions, slow CKD progression, and lower cardiovascular death. Trials have showed these effects in people without established cardiovascular disease and are now recommended for all, not just the high-risk subgroups. What this means in practice is that now the default first-line choice is metformin and an SGLT2 inhibitor, not metformin alone. More people will start dual therapy earlier, meaning that we will need to discuss SGLT2 inhibitor side effects, like the risk of genital infections, volume depletion, and renal monitoring from the start. In those who can't tolerate metformin, an SGLT2 inhibitor alone is acceptable. We also need to consider the fact that SGLT2 inhibitors will now be prescribed long-term unless there are specific reasons to stop them. And if further glucose control is needed, add-on agents remain available, but they now come after the SGLT2 inhibitor, not before. The next group is the obesity group. For people with type 2 diabetes who also have obesity, the draft recommends also starting with metformin plus an SGLT2 inhibitor. However, if further treatment is needed to reach glycemic targets, we will add a GLP-1 receptor agonist if initial therapy was started 3 months ago or more. This will usually mean adding subcutaneous semaglutide, provided there are no concerns of frailty and they have preserved ejection fraction, that is, cardiac function is acceptable. If metformin is contraindicated or not tolerated, the pathway is to offer an SGLT2 inhibitor plus semaglutide. We are again reminded that GLP-1 receptor agonists and DPP4 inhibitors should not be combined. Therefore, if the patient is on a GLP-1 receptor agonist and further glycemic control is needed, the next add-on therapies are sulfonylureas, pioglitazone or insulin, depending on the case. However, if a GLP-1 receptor agonist is contraindicated or not tolerated or not appropriate, we will add the DPP4 inhibitor first, before considering other agents such as the sulfonylurea, pioglitazone or insulin, as all of these can lead to weight gain. And let's remember that previously, people with obesity were more likely to have a stepwise approach. Metformin first, then add on other agents, and then move to GLP-1 receptor agonists only at last resort and if specific BMI thresholds were crossed. The draft changes this. It brings semaglutide forward in obesity and when weight reduction is a priority, also giving more flexibility in continuing GLP-1 receptor agonists if weight or glycemic goals are lagging, as long as obesity remains a priority. Why is NICE making this change? Primarily because there is strong trial evidence that GLP-1 receptor agonists produce sustained weight loss, and additionally, evidence has accumulated around reduced major adverse cardiovascular events. And finally, another justification is that many people with obesity carry a higher lifetime risk of cardiovascular disease. So delaying GLP-1 receptor agonists may mean a missed opportunity to reduce morbidity and mortality. What does this mean in practice? Well, we will need to identify patients with both diabetes and obesity early and discuss semaglutide sooner than before. Shared decision-making must cover not only the benefits, weight loss, better cardiovascular risk, and possibly better quality of life, but also the downsides like GI side effects like nausea and vomiting, injection route, and monitoring requirements. We also need to assess frailty and ejection fraction early and avoid semaglutide if there's a concern that frailty might lead to harm, for example, unintentional weight loss. Or there is heart failure with reduced ejection fraction, which may be decompensated with GLP-1 receptor agonist use. And we will also need to monitor the effect on weight, glycemia, heart and kidney function, being ready to stop the GLP-1 receptor agonist if necessary. And finally, the last group today, the frailty group. The draft guidance states that if the person's level of frailty increases the risk of adverse events from SGLT2 inhibitors, we will consider metformin alone initially. If metformin is contraindicated or not tolerated, we will consider a DPP-4 inhibitor instead. After metformin, if further glycemic lowering is needed, we will give a DPP-4 inhibitor if not already used. And if a DPP-4 inhibitor is contraindicated or not tolerated or already being taken, we will offer pioglitazone, a sulfonylurea, or insulin, explicitly taking into account hypoglycemia and falls risk with sulfonylureas and insulin. Alongside this, the draft highlights the need for a medication review, aiming for the smallest effective number of drugs in frailty. How does this differ from the previous guidance? Earlier, frailty modifiers were less explicit, whereas now the draft makes frailty a front-door decision point. It deprioritizes SGLT2 inhibitors when volume depletion, hypotension, or acute illness risk is high. It elevates DPP-4 inhibitors as a low-burden alternative, and it puts structured deprescribing on the page. It also flags the hypoglycemia risk with sulfonylureas and insulin in frail adults, making us choose agents which are safer in that respect. NICE is making this change because frailty amplifies medication harms. For example, SGLT2-related diuresis and BP lowering can precipitate dehydration, orthostatic symptoms, acute kidney injury, and falls. GLP-1 receptor agonists can cause GI side effects and anorexia that risk weight loss in the frail. By contrast, DPP-4 inhibitors are weight neutral, have a low hypoglycemia risk, minimal hemodynamic effects, and simple dosing. The emphasis on medication review reflects evidence that polypharmacy and hypoglycemia are linked to falls, delirium, and hospitalizations in frail older adults. What this means in practice is that we will need to assess frailty upfront and let it shape drug choice and dosing. If frailty raises safety concerns with SGLT2 inhibitors, we will start with metformin alone or use a DPP-4 inhibitor when metformin is unsuitable. We will prioritize low hypoglycemia risk, being cautious with sulfonylureas and insulin. and we will use the lowest effective doses with clear sick day rules. We will perform a formal medication review, deprescribing where possible, and aiming for the fewest drugs necessary. And we will keep focusing on symptoms, renal function, nutrition, and falls, not just HbA1c. So that is it, an initial review of the new draft NICE guidelines on type 2 diabetes, focusing on the visual summary. In the next episode, we will cover the remaining 4 groups: CKD, heart failure, atherosclerotic cardiovascular disease, and early onset type 2 diabetes. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.